let's get started. So ladies and gentlemen, I'd like to welcome you to the update on COVID by Professor David Wilkinson. For those of you who may have joined us for the first time, David's a professor of primary care, but he did his master's in epidemiology at Cornell and spent 10 years in Africa working with the AIDS epidemic, and has a very unique level of experience and insight into infectious diseases, because that's the area he's specifically focused on. So as I said, David's going to give us an update of what's going on. He's going to answer some questions. We've had some questions submitted in advance, which he shall answer. But if you just want to go to the Q&A panel and add anything else at the end of the presentation, I'll help moderate those questions and we shall go through them all if we can. All right, David, can I pass over to you?
Thanks very much, Paul, and good evening to everybody. Thanks, as always, to everybody for taking some time to join us this evening. I'm going to share my screen with you and just walk through some slides this evening, just a few slides, and go through them reasonably quickly. But I do want to cover off a few different topics this evening and hopefully stimulate some conversation. I always start these updates with this standard slide of the epidemic curve in Australia, the number of new confirmed cases every day in Australia. And as I'm sure you're all aware from the mainstream media, the number of new cases in Australia now is really very low and is consistently really very low. In New South Wales, for example, today, there were 2 new cases announced this morning, which is remarkable and by far the lowest so far. There are many states and territories in Australia now where we are seeing very few cases or no cases at all. So what I have put on here, and I've deliberately presented it this way to give you a sense of scale, and this chart here shows the number of new cases every day in each of the states and territories in Australia. This is only over the last couple of weeks, and the scale is important to see. The scale on the left-hand side, it goes up to a maximum of 30. So as you can see, in almost every state and territory in Australia now, we have no more than, a handful at the most of new cases. And it's only in New South Wales and Victoria that in fact we are seeing new cases each day. And the other point to make here is that almost all of those cases continue to be either in return travellers who are in quarantine and therefore of no risk to the rest of the population, or in clusters, particularly in aged care facilities or hospitals. This graph shows very, very clearly that the curve is well and truly flat in Australia, has been for quite some time now, and so the growth in the number of cases each day is very, very, very small indeed, and you're all aware of this from the media, from the commentary from the Prime Minister and the Chief Medical Officer and so on. So for all intents and purposes, this phase of the epidemic in Australia is now essentially over, in inverted commas. It doesn't mean the epidemic as a whole is over, but this initial acute phase is well and truly under control. And it's fair to say very clearly that the authorities are quite surprised by how much the epidemic has come under control and how quickly it has come under control in Australia. This is, I think, an important graph because it shows in yellow the number of tests being done every day across Australia. And you can break this down on the original source by state, but you'll see that a remarkable number of tests are being done every day in Australia, around about 12,000. And the number of cases is very low and is falling. What's important here is as the number of tests go up, the number of cases is falling. This gives us all great confidence that we are not missing cases and that the blue line is a very accurate reflection of what's actually going on around Australia. One of the things I find very interesting, if you have a look at this is the hospitalization by the different states and territories. I think it's very noticeable that if you look at this blue line here for Victoria, 35% of all cases hospitalized. For Western Australia, almost 40%. New South Wales, on the other hand, only 5% hospitalized. And then interestingly, the proportion of cases that are in ICU and the proportion ventilated, quite interesting differences. And it'll be interesting to see why that might be as more data comes out. Now, a couple of graphs to show you what's happening in the rest of the world. This is a really interesting one from the Financial Times, and this shows the daily death toll. All right, so this is the daily death toll. The US, as we all know, is setting all sorts of horrible records with 2,000 deaths a day. And a very large country, of course, 350 million people, but 2,000 deaths a day. And you can see Australia down here with the number of deaths per day falling and is really very, very low now. There are other countries down here with us, New Zealand and a small number of others. And you can see the important thing here is the trajectory of the number of new deaths each day. Are starting to flatten out in most countries. One thing I will say is very interesting. It's easy in a country like Australia, when we have very, very small numbers, to have an accurate count of deaths per day. It's become clear already that the number of deaths in the UK and the US per day is not at all accurate. There are two problems here. One is deaths in these countries and Italy and Spain and France. Deaths outside of hospital are not being captured and coded correctly. So the real number of deaths from COVID will be much higher than this. And the other problem is that the per day count is not a per day count. It's the number of deaths that hit the reporting system each day. So all of those inaccuracies are currently being ironed out. And it means that these numbers will in fact be quite a lot higher. But it's interesting to see how the epidemic is playing out. There's been this rapid increase over, 2, 3, 4 weeks, and now a flattening. But only in a small number of cases, like Australia, is the curve turning down. A similar graph here, but this is the number of new cases. This is a rolling average, a 7-day rolling average, just to smooth all the jiggling out around. And again, you can see Australia here doing really very well now. And other countries, Norway, Austria, South Korea, very similar. And New Zealand, right down here, in fact, has broken the zero as a 7-day rolling average. So it gives you a sense of relatively how very well we are doing compared to the rest of the world. I thought it might be interesting this evening to give you a sense of what's happening around the world in terms of treatment. There's a very interesting organization called the COVID-19 Plasma Alliance. All the relevant companies and foundations supported by the Gates Foundation are working together, and the Australian company CSL is a major part of this, working together to do all of the necessary research about the use of plasma and intravenous immunoglobulin as a possible treatment for COVID. And it's interesting to see how rapid the development of these international collaborations is. No signs yet of effective treatment. And the advice from COVID is that it's going to take months for all of this to occur, but everybody is working on it. The potential here is enormous. Similarly, and the Gates Foundation playing a major role in a lot of these initiatives, I thought it would be interesting for colleagues to be aware of something called the COVID-19 therapeutics accelerator. It is what it says. This is a global collaboration again to identify all of the possible therapeutics for COVID-19, and then to facilitate collaboration between all of these groups so that studies can be done really quickly. Results can be published very, very quickly, and there's a big push on in this space at the moment. Again, no definitive information yet, but it does look like hydroxychloroquine is no use, and a very disappointing initial result for Gilead's remdesivir antiviral drug. But it's not the end of the game yet for any of these drugs. More studies underway. In terms of vaccines, there's a thing called CEPI, again supported by the Gates Foundation, and this is all about epidemic preparedness. And the vaccine research is being again enabled and facilitated through this. There are about 100 potential vaccines at the moment being studied very quickly. You'll be aware, perhaps, again from the media, that in Oxford, the first candidate vaccine has been given to human volunteers, testing, of course, safety and immunogenicity. Again, vaccine development is months and months and months in the making. Now, just to bring all of this to a close, and just to try and give colleagues a little bit of a broad sense of the situation around the world and some of the broader policy issues around COVID that are relevant for those of us as doctors, is there's quite a lot of discussion about what the most effective response to COVID is. We are all aware of the massive disruption to society with the lockdowns that we're all facing. Again, here in Australia, certainly in New South Wales, the lockdowns are not too bad. They're pretty restrictive, but not too bad. Many of you, like me, will have friends and relatives in the UK. They're getting close to despair, is what my friends and relatives are telling me. Very, very unsettled by everything. It looks like the UK is going to continue with their lockdown. Only now are some countries in Europe starting to ease up. And there is, nobody knows how effective these lockdowns really are and how severe they need to be. And this graph is an interesting one, I thought, that compares the UK lockdown with the red line to Sweden with the lockdown, and it looks at deaths per million population. And excuse me, Sweden has been quite relaxed in its restrictions. Cafes and restaurants are still open. People are being asked to socially distance. Schools and universities are open. Their deaths per million are lower than in the UK. Now, there are other reasons why that might be the case. This is not definitive, but there is concern at the moment in some parts of the medical research community that actually locking people up runs the risk of increasing the number of cases, because most transmission is occurring in households. It's not occurring out in the wild, if you like. So just thought it was interesting to share this, because there is quite a debate underway about how strict lockdowns need to be, how you then ease them over time. And this is really relevant, because if we all get a second wave, it would be good to know how much restriction you really need to employ. It's interesting, just to close things off, about how the Australian public is responding to the government response to COVID-19. Now, none of this is political. It's just interesting, the levels of support. So the question given was, overall, how would you rate the government's response to COVID-19 outbreak? And the line to look at here is the net good line. And over here on the right-hand side, in March, about 45% were supportive, And that has consistently and steadily increased, interestingly, to just a few days ago, the 20th of April, 65% of respondents net good, only 15% net poor, and the rest, were ambivalent about that. So a lot of support in the community for what is being done. And the last one from me is I think this is the big story of the week from a medical point of view, a clinical point of view. A very important paper in the New England Journal of Medicine, which indicates they studied an outbreak in a nursing facility in the US, and they found very high levels, a high proportion. More than half of the people, the staff infected in the nursing facility were infected and had high viral loads while they were pre-symptomatic. So these were people that had no symptoms at the time. They were swabbed. They were found to be COVID positive with shedding virus, and then they became symptomatic a couple of days later. So I think a landmark study, actually, and it speaks back to the point I made at last week's update of the findings from the outbreaks on cruise ships and military ships, where high levels of infection were occurring in these closed communities, these outbreak-rich communities, and a third or a half of all of the people infected are asymptomatic, or more accurately, pre-symptomatic. So last slide, what are the hot topics? Well, I think aged care is a real problem. We're seeing these outbreaks pop up all around the place. All of the issues on Sydney's beaches with too many people coming up and crowding around on the beaches, creating a policy problem. We're still not really clear what the plan is, how to ease the restrictions. You'll all be aware that today New Zealand moves from level 4 to level 3 for 2 weeks, and then they go to level 2 if the numbers are still low. The UK, it looks like Boris Johnson is going to keep the lockdown going. Terrible implications there. I think that a terrible situation in the UK. We heard over the weekend that some Australian states have started to ease the restrictions. WA and Queensland, the New South Wales Premier indicated this afternoon that she will start to announce a sort of gradually rolling easing of restrictions here over the next few weeks. And I think what we're seeing here, colleagues, is a shift from having, if you like, fixed the immediate health problem. There is terrible concern in government, and we're hearing this at the senior university levels, real terrible concern in government about the impact, the social impact, and very, very importantly, the economic impact. And what I think our leaders in Australia are now starting to talk to us about is the balance between opening up society and opening up the economy, and the cost in number of cases and deaths that will have to be paid for that. They're giving us this sense of that balance. Certainly the Premier of New South Wales is starting to do that. What does the future bring? Huge uncertainty, right? I mean, just nobody knows how this is going to play out. It's not as if this will all settle down in the next few weeks and we're finished. It's just great uncertainty. And then finally, implications for the control of asymptomatic infection. And I know that's a great concern for our clinical colleagues, very understandably. And what I intend to do is make next week's update have a bit of a focus around exactly that issue, to try and give a little bit more advice about how we can all protect ourselves, both in a clinical situation, but also in the wild, from people with asymptomatic infection. Thanks very much, Paul.
Thank you, David, very much. We'll get you to unshare your screen and we'll be off we go. All right, so we've got a few questions. So just to remind everybody, if you would like to ask a question of David, at the bottom of your screen is a Q&A box. Click on that and type in the question. If you're on a PC, if you're on an iPad, it'll be up on the top right-hand corner is the Q&A. David, if you've got the question panel, I'll sort of read them, but obviously some of them have got lots of words in them or words that are a challenge for me, being a non-clinician, but we'll start with Alison's first. Is there any evidence the virus is more active in colder temperatures, i.e. any implications for winter other than the comorbidities like the flu?
Yeah. So it's speculated a lot. I'm not familiar with any evidence at all beyond some early studies in laboratories that try to look at how long the virus is viable on surfaces under different atmospheric conditions. So I think the truth is it is speculative at the moment. There is certainly interest in whether some of the variation we're seeing in different countries is partly due to the weather, the climate in those countries. But there's no good evidence on that. There is concern in Australia that we're heading into winter, of course, and that means flu season, and the implications of what that might be, because we know that respiratory viruses tend to spread more in winter. So I think it's a real worry, and I think it has serious implications, and it's going to be monitored very, very closely.
Awesome, thank you. Francis has asked, I've come across some grave concerns expressed by intensive care specialists in the US in regards to the unpredictability and serious multi-organ disease that COVID can cause in infected individuals. What are your thoughts on the easing of restrictions, say here in Australia, in light of the fact that a vaccine is many months away at best, and the inevitable second wave, however small or large, result in more positive cases? All of this time, we know little or nothing about how to effectively treat infected individuals, and support is the best treatment.
Yeah, well, Francis is hit the nail on the head, as he does most weeks, and I certainly am reading the same sort of stuff as Francis, I'm sure, and also, you know, the studies are now starting to be published on the experiences in the UK hospitals and the US hospitals, and I have a couple of friends here in New South Wales who have been involved in treating some of the COVID patients who get to ICU here in Australia. I think it's fair to say that to characterize the condition clinically amongst people who get seriously unwell is the specialists I'm talking to are saying this is not like anything else they've treated. They're still trying to figure out actually how to best support patients in ICU. Outcomes once you need ventilation are really very poor. They're now moving into trying to avoid ventilation at all costs. And there is this cytokine storm phenomenon where people are doing fine for days or holding their own, and then suddenly they crash and go very, very unwell for a period of time, and then often die. So the numbers are important here. I think two things. One is it's still true that the vast majority of patients, people who become infected, do not get sick or get very mild symptoms, and the hospitalization rate, as we've seen with the data I showed earlier, is relatively small. The death rate in Australia is running at about 1.5% at the moment. So this is meaningful, it's significant. The challenge from a policy point of view and a lifting of restrictions point of view is very simple. How much economic and social harm is the country willing to take on the other hand, the cost is the number of deaths. That's the balance that's got to be made here. You know, 10, 15, 20% of the population unemployed, the borders closed, nobody can travel anywhere and do anything, versus, you know, X deaths. That's the policy decision. That's the policy situation. And that's what Australia is facing. So it's very clear that the political leadership and the medical leadership is dead set on keeping the number of cases in Australia really, really low. At the same time, it's clear that they recognize that the economy has to be restarted at some level. People have to be allowed to move about more. And I think what we're going to see, Francis, over the next few weeks and months is this delicate dance of easing restrictions, testing like mad, reacting to outbreaks and damping everything down really quickly to minimize the number of people hospitalized and minimize the number of deaths, while at the same time letting the restrictions ease up. Very, very complicated one, but that's the essence of the situation right now.
Okay. Next question, David. Heard the dermatological signs like a macropapular rash present in big toes is one sign of COVID. Is it the case?
I've not heard of that one. I don't know. No.
Okay. Right.
Yeah, Maya always comes up with good ones. Got me on that one.
Yeah. All right. And obviously, I suppose more of a question around obviously that, you know, there's this conspiracy theory / question in the community as whether this is actually a biological weapon gone wrong or it's man-made, or, you know, is there any specific view or thought on this?
Well, you know, it's interesting, isn't it? I would have thought that if it was man-made, that there are so many research groups now that have the genome and have looked at it, that we would know that I mean, I'm no virologist, but I would have assumed that there are so many independent, trusted research groups who would have said, well, look at this bit, look at that bit. You can see that makes it man-made. So that's one view. The other view would be that Wuhan was the source of this virus. That looks very clear. And Wuhan has a virology institute in China. I've been there. It's there. It's an extraordinary facility. And I have no idea, but I would imagine that they do biological weapons there. So, you know, who knows, but you would have to think that the fact that we have the virus, we've got the genome, that if it was man-made, I reckon the virologists would have identified that. Yeah.
In fact, there's actually, I saw a really good article last week, basically said it was almost impossible to be able to replicate this in the man-made environment. Okay, just from Chris, sorry. So yes, Chris will be presenting and pushing up this presentation. David, the next question that Chris has obviously got around the plasma treatment proposed. Yep. So just maybe read that out and sort of explain it.
Yeah, so the question there is the plasma treatment pooled sera, or does it have to be HLA compatible? So Chris, what they're doing is initially the COVID Alliance is collecting serum from COVID patients. Of course, they will purify that stuff, and then they're going to run that through clinical trials. Of course, the problem is we don't know yet whether antibodies to COVID are protective, right? Not all antibodies are neutralizing antibodies. In other words, not just because you raise antibodies to an infectious agent doesn't mean that the antibodies protect you. Example, HIV. HIV antibodies are not protective against HIV infection. So that's the first step. What CSL and all the others are doing, Chris, is now working on obviously on synthetic plasma options there. So you know, that will then be pure antibodies and will be HLA compatible, you'd have to think that this has got a good option, has got a good runway, at least as a treatment for the more severe cases. So I think it's fingers crossed on this one.
Okay. Another question, Francis. I guess as a follow-up, are we going to see a lot more numbers of long-term adverse clinical outcomes for positive cases apart from deaths?
We seem to be. I think that's right. I think there are grave concerns around chronic lung damage, a lot of concerns around kidney problems. And look, I think you know, the research is really starting to come out now. The fundamental descriptive clinical research is starting to come out, and we're starting to really learn the realities of COVID illness, and it is not pleasant at all. This is not pretty at all, and we've got a long way to go. We've got a long way to go.
Originally, I was looking forward to get it so I could get my COVID passport so I could actually be allowed to travel. But I must say, after I've read more about it, and obviously the WHO coming out yesterday and basically said there is no such a thing as much as Chile's moving forward with it, by the looks of it. Yeah. It doesn't look like that's going to be the case either. So it's going to be very interesting, I think, once again, for travel, definitely in the near term. So David, that's all the questions we've got. So I would like to thank you very much for that. I'd like to thank everyone else who's been participating. I just want to let you know about on Thursday night, we've got a very special presentation by Dr. Sharon Sykes, and we're going to be doing a presentation on how to screen and manage domestic violence in the general practice environment. So as we're aware, one of the social impacts of what we've had to go through, obviously there's been a very large increase in domestic violence, and we've got a specific presentation to assist the doctors in relation to obviously identifying and managing that within their clinical environment. And then on May the 7th, we've got a Master Physician series, which we've developed with SkinCeuticals, which is basically COVID related around telehealth, growing, you know, online sales, managing finances. So really just, I suppose, looking at some of the other economic impacts that, as I said, there is obviously the social, and then there's also the economic impacts of this. And it's interesting that, you know, medical practices who we would have believed to have been probably relatively well protected has turned out conversely to be almost the opposite. So we are looking to help support practices through that. And next Monday, obviously, we'll have David with his update and obviously focusing on the asymptomatic side of it, which will be very, very interesting. So thank you very much all for your time. You'll be sent a recording of this tomorrow to pass on to your colleagues. Wish you all the best, and we'll look forward to speaking to you very soon. Thanks very much for your time.